Now let's talk about the pressure control ventilation or PCV. Normally we start with volume control mode. We set a fixed tidal volume, for example 400 ml, and the ventilator delivers that exact volume with every breath. But here's the problem. Some patients have very stiff lungs, especially in case of ARDS, pulmonary fibrosis, or severe pneumonia. When lungs are stiff, they are difficult to inflate. So to push in that fixed 400 ml, the ventilator must use very high pressure. That's when you start seeing high peak pressure alarm like 35, 40 or even 45 centimeter of water. High pressures can damage the alveoli, ruptures them and cause barotrauma. This can lead to pneumothorax, subcutaneous emphysema or sudden desaturation of the patient. So in this patient, volume control becomes unsafe. Let's understand this with an example of ARDS patient. Let's say you set tidal volume of 400 ml and the ventilator is using 42 centimeter of water pressure to deliver that volume. The alarm is ringing and this means the lungs are too stiff and you are hurting them. Here you must switch to pressure control mode. So actually what happened in PCV mode? In pressure control you set a maximum pressure, for example 22 centimeter of water. The ventilator will never exceed that pressure. Now with that pressure limit, the ventilator tries to give air and whatever the volume the lung accept will depends on the patient's lung compliance. In other words, instead of fixing the volume, you fix the pressure and the volume becomes variable here. This prevents further lung injury. Let's talk about second example, severe pneumonia. In severe pneumonia, lungs are full of secretions, inflamed and heavy. If you give a fixed 450 ml in volume control, pressure shoots up to 38 to 40 centimeter of water. Switching to PCV allows you to cap the pressure at 20 to 22 centimeter of water, protecting the lungs. Yes, the delivered tidal volume may be lower, like 280 to 320 ml, but safety comes first. You then adjust PEEP, FiO2 and rate to maintain oxygenation. So in summary, use PCV when pressure is becoming unsafe in volume control, especially in ARDS, fibrosis, pneumonia or any stiff lung condition. In PCV, you set the pressure, you protect the lungs and you monitor the tidal volume delivered. This is the basic and safest approach for low compliance lungs. Now let's talk about the drawback of PCV. So imagine the situation: the patient suddenly develops secretions in the airway or bronchospasm, or the ET tube gets kinked or partially blocked. Now the airway resistance increases, but the pressure is locked. The ventilator cannot push harder. So what happens in this situation? Delivered tidal volume drops, minor ventilation falls, carbon dioxide is not washed out, and the patient can develop respiratory acidosis. That's why whenever you use pressure control mode, you must continuously watch the expired tidal volume on the ventilator screen. If you see the tidal volume dropping, for example from 400 ml down to the 200 ml and 180 ml, your alarm should go off in your mind, because this means either there is secretions, bronchospasm, tube kink, or the lungs are becoming stiffer.